Well, welcome back to another episode of Dr. Y. We've had another viewer question. Dear Dr. Y, how accurate are lab test results after a massive transfusion? For example, if a patient receives a vitamin D test shortly after a large volume transfusion, would the results reflect the true vitamin D level, or could it be affected by the transfused blood? Well, that's an interesting question. Not surprisingly, we don't have any randomized control trials for such circumstances, and for ethical reasons, we'll probably never have that data. So we're going to look at simple transfusions. But even here, we have very limited empiric data. Instead, we rely on expert opinion. So what is that expert opinion? Most analytes are fine within 4 to 6 hours after a transfusion. So how did they come across this conclusion? Well, let's try and figure out why. A massive transfusion protocol is called when you expect to need at least 5 units of packed red blood cells over the next 4 hours. So this is typically seen after a major trauma, after some surgical complication, or if there's been extensive postpartum hemorrhage. While the exact details will vary depending on the hospital, most hospitals in Canada now have a massive transfusion protocol. A statistically meaningful change in an analyte's concentration can be formally calculated looking at biological variation data. Each analyte is going to have a unique value. Some analytes don't have biological variation data. So we commonly use a shortcut, which is about 10% as a rule of thumb as a significant change. So some analytes are going to be present solely in the blood. Some are going to be exchanging back and forth with what's in the cellular component, and some are going to be bound to proteins. So let's do some calculations to see how big the effect of a transfusion is on analytes. So a healthy adult human has a blood volume of approximately 2.4 to 2.8 liters of plasma in circulation, which for our purposes we're going to call water. However, that water is in equilibrium with the rest of the body water, which totals 22 to 40 liters. This exchange is relatively rapid. In fact, we set the maximum speed of a transfusion or an IV to avoid circulatory overload. So basically, to allow the body to have managed to do the equilibrium. To put this into perspective, 15 minutes after transfusion is over, with 95% confidence, the hemoglobin levels will be within 6 grams per liter of the value seen at 24 hours. So, for all of our calculations, we need to consider the total volume of water in the body, not just what is in the circulation. So, 10% of 22 to 40 liters is 2.2 to 4 liters before we would expect to change most analytes. So, how much do we give in a transfusion? Well, a unit of packed red blood cells has between 250 and 350 milliliters. 200 milliliters of that is in the form of erythrocytes. So 100 milliliters is in the form of the additive solution with about 30 milliliters of residual plasma. A unit of platelets is 350 to 400 milliliters. Now, depending on the way you prepared the platelets, exactly that fluid is, and the amount of it will vary. But as a conservative calculation, we can say about 300 milliliters for a bag of platelets is typical. Fresh frozen plasma is typically dosed at 12 to 15 milliliters per kilogram. So for a 75 kilogram male, we can calculate that that's about 1 liter of fresh frozen plasma that's given. Fresh frozen plasma is plasma, so it's going to represent the values that for each analyte that the donor had had. So for the most part, these are going to be normal values. For our calculations, we're going to assume a worst case scenario. So where either the donation or the patient itself had a concentration of 0, whilst the other had a very high concentration. And again, for most analytes, this is going to be an overstatement, but we want to see what a worst case scenario is. So if we have a transfusion, we would receive 5 units of packed red blood cells, a bag of platelets, and about 1 liter of fresh frozen plasma. Add that up together and we have about 2 liters. So we're just right in the point where theoretically we might start to affect the concentration of analytes. In some ways, it's a bit of a remarkable finding that we certainly haven't done as much dilution as one might fear. But we also have to consider a few other things. We know the body is not static. Analytes will move back and forth from the cells. We will also have metabolism happening. The water itself won't be static. Physiologic processes are still happening. Respiration, probably increased due to the massive transfusion, will allow water to be lost, as will water going into the urine, lost in the feces, lost in the form of sweat. And this is in addition to any pathological loss of water. The patient may be losing blood to the outside world. Perhaps they have broken skin because they've got some abrasions or burns, and so the transpiration is increased. Or perhaps there's some swelling, which is locking up some of that water. And so that 10% we saw is going to be even slightly smaller. But we also have to consider the clinical utility. The patient has just gone through a life-threatening condition. Do we care if an analyte is off some subtle amount? No, we care whether the patient has renal failure or hepatic failure. So we're looking at 20, 30, 50% changes to be significant. The other thing to consider at this point is that almost certainly some sort of inflammatory cascade has been started. This is going to change the metabolism for the patient, and so that's going to have a much more profound effect on the concentration of the analytes than the small dilution effect that we're going to see. Many substances are bound to proteins. So we have a concentration of a drug and a concentration attached to various proteins, and they're in equilibrium. So within the lab, for example, if we had a free T4, which exceeded the analytic capability of the instrument, you might think, well, let's do a dilution. So we do a 1 in 10 dilution. That will affect the free concentration by less than 1% due to that equilibrium constant. Now, free T4 is a bit of an abstracted example. However, many analytes in the body are similar with the cells. So the cells are high concentration. So if the concentration in the blood were to decrease, the natural equilibrium would be the analyte would move from the cell into the blood to normalize the concentration of that analyte. Now, with all of that said, though, there is one major class of analytes that are profoundly affected, and that's anything associated directly with the erythrocytes. So, for example, hemoglobin A1C, TPMT, RBC folate, RBC magnesium, G6PD deficiency, hemoglobin variants. Oh, sure, analytically, we will get exactly the right result. However, clinically, what does it mean? The result is going to be a combination of what the donor had and what the patient had. So it may not be clinically meaningful. So what we have to do is wait for enough time for those erythrocytes to have disappeared and for the body to have replaced them with its own. Minimally, that's about a month, ideally at least 2 months to do some of these concentrations. Now, as a final note, there's one important caution I have to say. Ordinarily, we say that if you have an IV, that we want it stopped before you do the blood work. This is an exception to that rule. Here, we have a life-threatening condition, and that IV that's running for the blood is absolutely critical to save one's life. But we also have to consider the purpose of the blood work. Here, we're looking again at life-threatening abnormalities. And so for things like our CBC, the coagulation, blood gas parameters are accurate enough during the transfusion to still guide us for management of the patient at that point in time. Long term, maybe not the right choice, but in the short term, it'll be good enough. So at the end of the day, this brings us back to our original question. How accurate are lab test results after a massive transfusion? Well, for the most part, they're pretty good within 4 to 6 hours, with the major exception being of the erythrocyte things, in particular things like hemoglobin A1C. So thank you for that really interesting question. Please keep your questions rolling in, and I'll see you next time on Dr. Y.